Hello, I'm Mark McClellan. I'm the director of the Duke-Margolis Institute for Health Policy. On behalf of Duke and all of our participants here today, I am really pleased to welcome you to this timely and important webinar focused on the CMS Innovation Center's newly released strategy. Last week, the Center for Medicare and Medicaid Innovation, CMMI, released this strategy with the goal of accelerating reform and improving the health of every American, highlighting three key strategic pillars on a foundation of increasing taxpayer savings. Those pillars include evidence-based prevention, driving choice and competition, and empowering people to achieve their healthcare goals. For those of you who follow Duke-Margolis, you may have participated in our National Health Policy Conference last week, where both Dr. Oz, CMS Administrator, and CMMI Director Abe Sutton and a range of others, Governor Wes Moore and many others, discussed these and related strategies at a broad level. The goal of today's webinar is to go a bit deeper, drilling down on each of these three pillars within the strategy to talk about both the near-term opportunities for moving forward, as well as how these steps can advance a longer-term vision for a health system that is more affordable, accessible, personalized, and effective, and reflects the goals of value-based care and prevention. Last, as we get started, I wanted to thank our Duke-Margolis team who have been involved in this webinar: Winbo Bai, Audrey Ford, Luke DeRocher, Hannah Vitello, Patty Green, Rob Saunders, and Frank McStay, as well as all of our panelists, and of course, all of you who are joining us today. And now I'd like to turn to Tim Lash to thank him and West Health for their continued partnership with Duke-Margolis to advance value-based care and the development of effective policies to support it. Tim is president of West Health, and Tim, thanks for being with us today.
Great. Thank you, Mark. And I appreciate everybody joining on this webinar. As Mark said, today's meeting is to go deep. And I think, in many ways, we're at, a very historic time, in healthcare. There's disruption at every point along the value chain, right? We're seeing that on the supply chain from a technology and healthcare innovations perspective. On the demand side, both the number of seniors, their need, and the population shift that we're witnessing, is truly historic. And at West, as Mark said, I'm president. I have the privilege of working with a team that gets up every morning thinking about affordability, high reliability, and the responsiveness for our healthcare system, and specifically for older adults. And I think now more than ever, we need CMMI's focus on evidence-based prevention and really scaling and accelerating our ability to think about measurable cost savings if we're going to catalyze the innovation that is occurring in the right direction. And I think when we combine that power and those priorities with West's research and other actors in this field, meeting like this can really create the evidentiary underpinnings that the health system needs and the policy that we need in terms of better access to data and the useful application of smarter technology and holistic care. And so we're really proud to be a co-host along with Duke-Margolis and joining the strong leaders on this group in closing the gap between where we are today, the current state, and delivering what truly matters to patients, the families, and taxpayers. So really, thanks again for being here.
Tim, thank you, and really appreciate your support. So let's get going. I want to now introduce Abe Sutton. Abe, it's good to see you again. You're, I think, rapidly becoming a household name in health policy and health reform circles. Abe is the director of CMMI and deputy administrator for CMS, and comes with a significant history of work in the public sector and the private sector around healthcare innovation. And Abe, you've had a lot of chances over the past week since the CMMI strategy was announced to talk about it. I'm wondering if you could recap in these three big areas that I've already introduced, what you're hearing. What are some of the main things that you're taking away so far as the strategy is being rolled out?
So, Mark, and thank you for hosting today's conversation, for gathering panels at such a quick pace, for discussing a strategy that folks have had really for a bit under a week now. And so I realize it's new for everyone. I'm grateful to all the panelists for engaging so quickly and willing to be part of today's conversation. It's been really positive getting to hear engagement from people over the last week. I think people seem to be excited that it's pretty clear where we want to go and what our goals are. And that's been affirming for the center, for our strategy, and for the work that we do. I think people have been good in recognizing the areas where what we're doing is in many ways continuous with what came before, but also calling out some new areas that they hadn't seen from the center prior to this. I'll call out tertiary prevention as an area where we really do want to invest. And we think that there is a potential over time to have an impact where the center hasn't spent as much time to date. I think people have asked questions on more specifics, more on what is the priority that'll come first if we think about this as something that'll be staged over years. And just given the nature of the Innovation Center and our work, we're really careful on what we share publicly. And so we are not going to, in a one-off conversation, share all that detail. But I think people have really been excited and energized and just wanted more specifics in certain areas.
Well, let's start talking about that. And then, as you said, we got some great panels that provide a wide range of perspectives on how these efforts can move forward. One cross-cutting theme that we're already hearing a lot from Dr. Oz about in terms of addressing fraud and using CMS systems more efficiently to get unnecessary costs out of the system is saving taxpayers money, and I would say beneficiaries for that matter as well. Is there any early steps that you see in terms of getting more of a clear path to cost savings into the CMMI models that are continuing, into some of the new ones that are starting to take shape? Can you say a little bit more about this area?
Happy to do so. And I think that this is something that struck me as important, even when I was participating in models and supporting providers as they participated. It was often unclear if you look at what counts as a saving. And so let's say you as a participant are claiming shared savings. That doesn't necessarily mean that the office of the actuary is going to score a model as a saver. And so that disconnect, and it's a disconnect that was really built in for just how benchmarks are set versus how the actuary would measure things, led to, I think, a disappointing track record in terms of savings for some models. Now, obviously, there are learnings that we take from that, and there are lessons that inform future model design that I think lead us to be better prepared now. So one of those lessons is that downside risk really matters for changing behavior. People respond differently when there's downside risk. And so in order to ensure that there's a pathway for certification through cost savings on our models, I think downside risk where we have risk-based models will really make a difference. I'm also hoping that we can make our models simpler to administer by having some standard design features that span across models. There were obviously some similarities between the Reach ACO model and the CKCC model. Having common infrastructure used across our models can make a difference just in administrating these models and ensuring that there's a path for us to scale them in a sustainable manner going forward. And so those are things that I think will come in there. I also think that there are some areas where the Innovation Center has historically not focused that can help us set up for our models to be savers. As we think about low value care, something at really the core of the MAHA movement is calling out areas where we have unnecessary utilization that could be harmful for folks and seeing how we could incentivize reductions in that unnecessary care and help guide people to care that's right for them, I think will make a difference on a cost trajectory in the long run. And so all of the pillars really build on this, on prevention, about avoiding costly disease, on empowering patients, about helping people make the this healthcare decision that is right for them, and choice and competition on really having the market condition that'll drive down costs over time. And so they really all move towards this goal.
Yeah, I appreciate the synergies that you're highlighting as, now we're sort of 15 years in on the Innovation Center, longer on value-based care, and these are getting to be more mainstream, if not the norm of care delivery, getting to more common features, predictability, building out from existing models. One other cross-cutting theme that comes across in virtually every time I get to speak with Dr. Oz is the importance of better data and technology-enabled care. That seems like a cross-cut as well across these three main themes. You already alluded to it in terms of better data being available, making it simpler and more confident for healthcare organizations to participate in these models. Can you say more about how you see the technology-enabled care focus spanning across these different strategic elements?
You're right. It's a critical focus for Dr. Oz. And I also think that it's the right moment to have this focus. If we think about the potential for generative AI and what can be done with technology, there's a potential for technology to massively increase our supply of healthcare in this country. If you think about how physicians and providers can be supported in the care for their patients, how people could be empowered with new access to information, and so that our existing healthcare resources could be stretched more effectively. There's a real potential here. There's also a potential for massive inflationary impact from some of these new technologies if we look at healthcare spending on technology. So I think about the use of AI scribes and how they help systems capture more services. Now, those services were delivered always, but now that there's more accuracy in the billing, so it's not fraud, it's not malintentioned, there is going to be more payment flowing out in order to reimburse for those services that are now accurately reflected. And so we're going to need to be very intentional in grappling with this and ensuring that we encourage the development of technology in a manner that increases supply and lowers costs, just based off our focus as the innovation center. And I really think that we can view tech as an accelerator of our broader efforts and use our efforts to accelerate tech development. So greater data collection, analysis, and analytic capabilities, and then the scalability of technologies are some things that we can make a difference on. And so if I think about the over 1,000 FDA cleared AI ML enabled machine medical devices that are now in use, what's the reimbursement pathway there? And can we make it more predictable for folks who are making investments in the next 1,000 AI and ML enabled medical devices so that they know that there's a reimbursement structure out there? We do use a lot of fee-for-service payment structures currently in Medicare for technologies. I'm thinking of like the transitional payments for new technology or like the separately billable services with their own CPT codes that get assigned. And so those, of course, increase cost pressure just by the nature of their design. And so I think we need to capitalize on AI's potential to invest in some targeted reforms to encourage the adoption of AI technologies. And I get very animated around that because I think it's something that could be really like transformational at the current moment in how we approach technology in healthcare.
You do get enthusiastic about this. I'm going to ask one more follow-up question here, which is you emphasized AI and technology not just being about ability to increase access, but also about ability to get more accurate data on a patient, the right place, the right time for that patient to deliver these services, which may have taken a lot more physician time and effort by teams or even by more automated AI-enabled systems. That seems hard to keep up with a fee-for-service schedule. How do you connect that to the push into value-based care that you've also emphasized as part of this strategy?
I think they align really well because if we think about it, value-based care is about empowering those closer to patients to make the best decisions for them and about incentive alignment. If we think about the power of these technologies, they have the potential to stretch providers, let them do more, and let them give more supports for patients. If this doesn't become a game of, is there a CPT code for this service in a 1-for-1 ratio, but instead is a, can I leverage this to help my patients live healthier lives? And you know what? I capture part of those savings because I'm in a risk-based ACO model. Suddenly there's a synergy between the two. And so I think this is something where the new technological capabilities that are out there will see higher adoption if we set this up right in value-based care oriented practices. And so these really are moving in the same direction.
Great. And there is one new development today. This is news as of this morning. CMS just announced a refresh of its Learning and Action Network, the Healthcare Payment Learning and Action Network, or LAN. This seems like also a cross-cutting issue for your strategy, the emphasis on getting more collaborations, deeper, more focused collaborations with the private sector towards advancing innovation center goals, sharing best practices, trying to get alignment across, say, states that are trying to make more movements and towards more efficient, effective, accessible care in their markets, working with employers even as well. Can you say a little bit about what you're expecting from this new iteration of the land to help deliver?
And thank you for drawing attention to this. This is late breaking as of this morning, as you well know, as one of the co-chairs of the LAN. That press release previewed, I think, where we're shifting and the focus that I'm excited about to see from the LAN. The LAN has, over the last 10 years, really been a catalyst for driving and accelerating the adoption of different alternative payment models. I'm really thrilled that the LAN's going to build on this momentum to move into downside risk, but also to bring private sector expertise to support our strategy. So I'm excited about the 4 cross-cutting industry work groups that were announced. So they parallel our pillars and then also a particular focus on technology. So there's one on evidence-based prevention, one on patient empowerment so people could achieve their health goals, and one on healthcare choice and competition, and then the final one on technology-enabled healthcare, because we want to have a particular double click on technology given its importance at this critical moment. And so I think there's a way that the LAN could help bring industry partners and collaborators and stakeholders to the table to help us inform how we're approaching things within the center and with CMS more broadly. And I'm excited about the collaboration.
And that cross-cutting focus on technology-enabled care seems like a fast one out of the gate for the new LAN, following on the recent request for information coming from CMS broadly about how to advance technology-enabled care. This seems like a good set of public-private opportunities to build on those initial steps.
Yeah, completely agree. And for those who have not taken a look at that RFI, I would encourage you to do so. There are questions specific to technology and value-based care context as well. And I think we would really value your input on that.
All right, now I'm going to use our remaining time together to help us transition to those panels that are going to be deeper dives into your 3 strategic areas. Well, let's start with evidence-based prevention. You mentioned there's a range of perspectives here that align with MAHA type goals. I think a lot of people, when they think about prevention, they think about interventions and early steps that lead to risk factors that lead to chronic diseases, like addressing obesity and healthy diets and lifestyle. I do want to talk about that a bit, but you also emphasized tertiary prevention. In between that, there's secondary prevention. Can you say a bit more about how you're envisioning CMMI acting on this broad prevention strategy that, as you said, is going to be in all models going forward?
I'll acknowledge that there is a lot here. And to help make it manageable and help deal with the reality that oftentimes upfront investments are necessary in order to see long-term savings here, we intend to be really grounded and really focused on the evidence for the type of interventions that we are pushing for. What this will mean is that we're going to track intermediary markers of success often. So he'll help identify some promising models or interventions, even if the full cost savings are not able to materialize in the time period.
Can you say a little bit more about what that might be? Is it an engagement with beneficiaries and steps beyond that, like changes in their behavior, changes in some early markers of chronic disease progression?
So I was thinking changes in early markers of chronic disease progression, just because I do want to anchor on outcomes metrics to the extent possible here. I think when we get to process metrics, it's possible to have a miss and to think, oh, this thing does matter, but in time we see it may not actually change behavior. And so if we could go to an outcome measure that might not be the cost savings reduction, but might tie to, your A1C levels,
Yeah.
that's something that would work and be promising. It won't translate in the time period of a model necessarily in a cost savings, but that would be something that I'd look at and say that's a quality impact that matters. Does that answer the question, Mark?
Yes. And then if you could, so that's primary, but you emphasize tertiary. So I assume that includes secondary somewhere in there as well.
We're not skipping secondary, definitely part of it. And I actually think about the work that we did when I was focused on patients with kidney disease. And
Yeah.
if you were able to intervene early on before the patient progressed through a lifestyle intervention, through changing their diet to delay progression, that's something that could make a real difference from a spend trajectory. And so setting up the incentive for that type of intervention matters. And what I want to do at the center now is when we think through our quality metrics and we think through the particular incentives we have people focus on, I want to orient to outcome measures and make sure that they are embedded in our models broadly.
And that's not just, I know some of the work that you've done is focused on beneficiaries with relatively advanced chronic kidney disease, where historically outcomes have not been good and high rates of complications, death, and costs associated with that. But it sounds like you're also talking about patients at kind of an earlier stage. I think you would know better than I do, but 6, 7 million maybe Medicare beneficiaries that have elevated markers of chronic kidney disease don't yet have symptoms. And that's a time when more effective interventions could be very helpful in slowing progression and avoiding future costs.
100%. I mean, this is something that I heard a paper on, I think it came out in 2024, about how if we look at CKD stage 3 patients who have other chronic conditions, the outcomes that they see are actually in a 2-year period very similar to people with CKD stage 4 and 5.
Mm.
And so we don't have a metric, have a pathway from the Innovation Center today to intervene on that population and empower
Yeah.
nephrologists and risk-based arrangements on that. And so that was something that at the time I wrote a paper on highlighting, hey, if from an outcome measure, if we look at the data, we really should give a path to intervene. Similarly, there are other patients with CKD stage 3 who do not have other chronic conditions, who I think there's timelines that you could see savings on and see quality improvement if we engaged with. And so kidney care, it's really obvious. I think in diabetes, it's obvious as well. There are a couple of areas where it's worth focusing in on. We obviously have the Medicare Diabetes Prevention Program in our portfolio as a center today, and that's an area that we should look at diabetes, chronic kidney disease, and other chronic conditions as well.
And can we turn now to choice and competition? That's another broad theme that includes both and overlaps with empowering beneficiaries, better information, but also about reforms in some of the models that CMMI has already implemented and potential new ones. You mentioned downside risk as maybe being an important priority here. I think you've also talked a bit, and Dr. Oz has as well, moving to mandatory models. What would you like to highlight in this area?
So there's a lot here. This is
Yeah.
one I'm very animated about, and I think matters because the underpinnings of our healthcare system, and if there's competition there, translate into if people are given the information to make decisions over their health. It translates into if there's competition to serve people, and I think it translates into better health outcomes for Americans. And so to the extent that we could promote the independent practice of medicine so that people who form relationships with patients and are part of their communities are able to care for them, that matters and makes a difference. And to the extent our models are built such that only large players with scale can win, I think that's a problem. And so that's something that I'm grappling with as I think through the design of our next generation of models, making sure it works for folks practicing in smaller practices, for folks practicing in rural communities, so that their communities have access as well. Now, when doing this, what I want to do is make sure that we have benchmarks that are competitive, that don't favor certain players over others. I want to make sure that there's transparency here. I want to make sure that the administration of our programs works for providers who don't have cushion in order to absorb blows from last minute changes. And so those are things that we're focusing on in a disciplined manner in our development now.
Right. And you did highlight in the release community health centers, rural areas, et cetera, where there's just a thin margin. And I think many of those organizations are looking, as you said, looking at these models, and it seems like tougher to participate than if you're a big, well-capitalized organization with a lot of infrastructure.
100% right. And what we need to do is develop the structure where we can support independent practice, support clinics, and make sure that they're able to succeed. Because I think those are entities that can form a relationship with patient and empower them to achieve their health goals.
All right, and I just would like to end with a few on the beneficiary empowerment pillar. That one seems very related in many ways to what we've already talked about. Better information to support beneficiaries and the choices they make. That fits in with the technology-enabled care emphasis that you and the entire leadership team at CMS has emphasized. It also obviously fits with prevention. We'll talk more about that in a minute. Any other points there that we've missed that you'd like to emphasize right now?
I would just call out that the president has emphasized transparency and empowering people with pricing information as a critical focus for the administration. And I think that's part of it. It's obviously knowing information on the quality of doctors on that. It's knowing the information of what can impact your health. But the pricing information is often a barrier that leads people to hesitate to seek care that they need. And that could lead to longer expenses 5 years down the road because you didn't get care along the way. And so I'm cognizant of that, and I'm keeping that in mind as we're doing our model design to respond to the president's transparency prioritization.
So, there's a tremendous amount of potential here, better data, better systems to support it around these, and better policies for these important goals. But it seems like we still have a lot to learn. And one thing that has been challenging in the United States is rapid learning at scale. I know CMMI is currently working on a rapid cycle innovation program. You've emphasized in the RFI on technology that you want a pathway towards rapid testing. Can you say a bit more about how CMMI can work with the private sector, work with health plans or healthcare organizations to accelerate learning as you try out these ideas and hopefully improve on which ones are working, which ones aren't, how to do it better?
So rapid cycle innovation, or this iterative testing, obviously is drawing on things that people in the private sector have done for a while now. You've got this poster versus that poster, which gets the engagement, which gets people to come in. And there are tactics like this that already in use in healthcare, like this message to come in for a follow-up appointment versus that message, which text resonates with people, the shorter, the longer, what gets you to click the link and schedule. I think that there is a way for us to partner with people participating in our models to do some of these tests. If I think about for a subpopulation within an accountable care organization, let's focus in on this set of providers in the ACO, send this message with that one, send that, and then draw out the data across 4 different ACOs that we did this with and share what resonated and what worked with participants in all of our in that entire model, as well as with the general public. I think it could build on that and go beyond that. I think it could reach, let's test the impact of a different set of patient empowerment tools, different set of devices, and see the impact that that could have for patients. And this could be something where we don't take 5 years to look at it. It's not a full model test. It's not something we're certifying in that way, but it gets us information on what works and what folks respond to. And so,
And helps the organizations themselves do better. Yeah.
exactly. And that's why where there's like aligned interests like that, and we're coming in with the standardized design here and picking up that, I think it can work for the ACO partners. And so I'm interested in deploying this across multiple different innovation center models and seeing, all right, in this context, it works like that, in that context, it works like that, and picking through a couple of different tests that we could do and iterate on.
Abe, thanks so much for taking this time to go deeper. You give us a lot of material for the rest of this session. I know CMI is looking for more input from the public. We've talked about the RFI. We've talked about the LAN as opportunities to participate. Anything else you'd like to call out for ways for people who want to get involved and contribute more to do so?
I'd say don't be a stranger. If you have been in conversation with the center before, please pick up that channel, continue the conversation. We want to get input. If you have not been, reach out, send us thoughts. We want input on our model design for the existing models and for new ones, and welcome that. And I just want to reiterate my thanks to all the panelists taking part in today's conversation. I'm eager to learn from your perspectives on our strategy and welcome critiques and how we can improve going forward. So thank you, Mark, and thank you, Duke, and the entire team for organizing this.
Thanks to you and the whole team at CMMI, the ones who've been there for a while and are gearing up again, the new leadership all coming together to advance this work. We look forward to, I'm sure you're going to be out there a lot advancing these efforts, and we look forward to hearing more. Thanks, Abe. So we're going to go right into building on some of the topics we just discussed with our first panel on CMMI strategy to promote evidence-based prevention. And you just heard just heard Abe give a big introduction to that. I'd like to quickly introduce our panelists. Dr. Rashina Shalera is director of the North Carolina Integrated Care for Kids Innovation Model and an assistant professor of pediatrics and population health sciences at Duke University. Dr. Mark Hyman is the co-founder and chief medical officer of Function Health, preventive health and longevity innovative company, and also the founder and director of the Ultra Wellness Center, a specialty practice that focuses on treating complex chronic illnesses. I think it resonates with that secondary and tertiary prevention that we just discussed. Will Robinson is senior vice president of accountable care and policy at Harmony Cares, which offers comprehensive home-based healthcare services, including the Medicare beneficiaries, also is a CMMI alum himself. And Shashi Sim is the executive vice president for health policy, research, and strategic partnerships at the Episcopal Health Foundation, which has been advancing prevention-oriented collaborations across community-based organizations, safety net organizations, and a wide range of medical and population groups in Texas. So let's get started with this big notion of making prevention in all of its types a cornerstone of CMMI initiatives. I'd like to start with comments from any of you like to make them. Maybe Rashina, I'll start with you on opportunities to build on steps that you've seen. So this is an area where there is some evidence, but an opportunity to do a lot more.
Thanks, Mark. Thanks so much for having me. So yeah, we've been really excited as a child health focused innovation model, the only innovation model focused on children, to see the major focus on evidence-based prevention in the new strategy. And I think we have a lot of learnings from all of the integrated care for kids models on how some early potential indicators that can be incorporated into existing pilots, as well as ideas for how to really think creatively as new pilots are designed by the Innovation Center. So one of the things that we've really learned as we take care of kids in the integrated care for kids models, which is a model focused on Medicaid enrolled children and their families from birth to 20, is the importance of a whole household or a family. And so care for kids, as all of you know, is by its very nature preventative. It's only a very small portion of children that are in the hospital or that are very expensive or high utilizers. So we are really focused on thinking about how do you identify kids who are going to become the high utilizers or who are going to become the adults with complex chronic conditions. And so there's a huge, vast body of evidence on what factors lead to complex chronic disease. I was excited to hear Abe earlier talking about things like the importance of A1C and thinking about diabetes, but we can think really carefully about things like diet and nutrition at the family level. So thinking about, we know that kids don't live in a silo. They're in the context of their grown-ups or their caregivers, their families, their communities. And so one potential opportunity is to really think about how do we measure both both disease as well as intervention at the family or household level. So not just thinking about an individual child who for many, many years is going to be healthy, most likely, but also thinking about what is their context. And so what I mean by that is almost always, if you, there's a lot of literature, particularly in the obesity literature, showing that the family dynamic and family health is really important. So you might see an adult with A1C or a high BMI who has for many years had interactions with the healthcare system. And what you don't see is a connection to the other people in their household. But if you can intervene, think about intervening on diet and nutrition at the household level, think about physical activity at the household level, there's a real opportunity to bring the whole family along as you're thinking about both preventative measures and outcomes. And in children, we often have an issue with thinking about what is a return on investment. And so when CMMI is thinking about cost savings for children, we have to look over a very long timeline to see that. But when you're thinking about children as they connect to their adults, it's much easier to think about prevention and connecting that to cost savings in the context of a family, because you have maybe a longer tail for a child, a shorter tail for an adolescent, and for an adult, you can see cost savings within a year. And so that's just one creative potential option to think about how we can do this with this real focus on evidence-based prevention and data interoperability.
Great. Well, thanks for that overview. I know you're taking steps to put all that data together, including from non-medical sources, school engagement, and even juvenile justice in a constructive way to identify risks and head them off. Mark, Dr. Hyman, maybe turn to you next. And by the way, I know you've got a lot going on and traveling with all the interest in these issues, translating evidence into evidence-based prevention that can be facilitated with policy. We've talked a bit about some of the work that in our previous discussion about some of the work that you've done on this early stage prevention side, but I know you're also deeply involved along the lines that Abe was describing in secondary prevention and changing the way we think about treatment for chronic diseases.
Mm. Yeah, I mean, I think there's a real opportunity to reinvent how we deliver care and what we deliver. It's really both what we do and how we do it. And the what really has to be focused on, I would call the science of creating health. And at the risk of sounding a little hyperbolic, I think when you create health, very often disease goes away. And I always say that disease is the body's best attempt to deal with a bad set of circumstances. You change those circumstances, disease will go away. Diabetes is a great example. You take someone who's eating a diet that's high in refined starch and sugars and ultra processed food, and you put them on a whole foods, low glycemic, higher fat diet, and you can reverse their type 2 diabetes. And that's been demonstrated over and over again. And also how we do it matters, which is delivering care in a way that drives behavior change. And this is the basic holy grail of medicine, which is something that hasn't really been talked about much. It doesn't really get talked about in terms of reimbursement or thinking about primary or secondary, even tertiary prevention. But you have to think about behavior change when it comes to lifestyle-driven diseases, or else you're not going to be able to solve them. And I think the care models around that have to be innovative, and can be done through both tech solutions, through virtual group models or in-person group models delivered through traditional healthcare organizations, or like the DPP through things like YMCA or community-based organizations or faith-based organizations. So, for example, I developed a program with a faith-based wellness program with Rick Warren, and we scaled that in his church to 15,000 people, and they lost £250,000, reduced medication use, hospitalization, and so forth. We also scaled that to hundreds and thousands of churches around the world, including over 30 churches in Cleveland that we did when I was there. And we saw, dramatic improvements in health outcomes. And it was just people supporting each other.
Great. I do want to follow up on those and how we can translate those very promising examples of success into scale, which has been challenging, as we've talked about from the top of this event in the U.S. healthcare system. Will, you're doing some of this too in your current work. Thoughts that you'd like to kick off with?
Yeah, sure, Mark. Thanks. And thanks to West Health for hosting this in addition to Duke-Margolis. I think stating the obvious, we live on the sort of end of this prevention spectrum on the tertiary prevention side of things. And prevention looks different for different populations. So when I say we, I mean Harmony Cares. We're the largest home-based primary care group in the country. We exclusively care for polychronic homebound or partially homebound patients. And for them, prevention looks a lot more like meticulously managing their often 6+ chronic conditions and working to keep them healthy and out of the hospital. I'll also note that there's an expansive view of prevention here that might also include prevention around suffering at the end of life, which I think is a big issue for our population, in addition to like disease prevention specifically. But Mark, your question is really about sort of what I think what tactical changes CMS can make to increase prevention in the short term around the models that Abe and the team are working on. And I give them a lot of credit and celebrate the strategy that they just put out. I think it's really helpful for them and the community for them to share that. I think we generally know, though, for these complex patients, what works, which is that we need to put primary care providers in the driver's seat and align incentives for them through, like as Abe uses, downside risk models. And the kind of tertiary prevention that really drives changes in outcomes and lower total cost of care is really much harder to do in fee-for-service. So we're active participants in High Needs Reach. It's a specific track within the broader ACO Reach program that's sort of uniquely dedicated and exclusively for patients with really advanced complex illness. And the track has shown real promise in terms of generating savings, lowering unnecessary utilization, improving quality. But just like the broader ACO program, it's scheduled to end after 2026. I think just like as Abe and the team are considering all of the different models and sort of portfolio review that's happening now, one of the things that we think is really, really critical is just the need to ensure two things, which is continuity and make sure there's no gap in a opportunity for organizations that care for these really complex patients to participate in downside risk models, and then also stability and a path to permanence. So that's another thing that I think Abe was talking about and is highlighted in this strategy. Like there needs to be a way for the community, the provider community, to really understand and be able to invest in a long-term model that we know will be around for several years. So I think it's not just about having a stopgap. It's about let's create a long-term vision for a ACO or whatever downside risk model is available for organizations that care for these complex patients. I also will just mention really quickly that like there's tactical things underneath the sort of broad need for continuity and stability related to model design that I think would be really helpful, particularly for patients that are in need of that advanced sort of tertiary prevention. And one of those things was actually pointed to in the strategy memo that was put out, which is additional flexibility for providers that are participating in these models. So one of the things that they pointed to was like the national and local coverage determinations associated with durable medical equipment, which of course in a fee-for-service context, Mark, like that makes total sense. Like you're not just going to like let DME go out the door without having some coverage limitations on it. But when you're in a full risk model, those coverage limitations often mean time that beneficiaries are waiting for needed durable medical equipment. And from working for an organization that cares for complex patients that have outsized DME needs, those delays are really significant. So I just use that as an example of something that I think the Innovation Center is clearly thinking about. They highlighted in the strategy, but that would be really helpful for the design of these sort of future models. So I'll stop there.
Yeah, and Abe did highlight that point in his earlier comments about how some of these steps may be easier in value-based models, especially if accompanied by rapid learning within the models and getting to, instead of, having to do a separate 5-year new program, building on what's there and making them more effective. Those are great themes for advancing the prevention work. I would like to bring in Dr. Sim. So, Shoshay, any points that you'd like to make, particularly from the perspective of working with a diverse set of organizations, including some of the ones that Abe called out that historically haven't been that engaged in value-based care and have had advanced support for primary, secondary, and tertiary prevention. What do you see as the best opportunities here?
Yeah, thank you so much, Mark, for this invitation. Yeah, I just going to briefly touch on 2 points here. I think one is really like the previous panelists about framing this as an economic incentive alignment issue. As as you had shared, Mark, the foundation, Episcopal Health Foundation, actually has really been looking at ways to create some policy alignment or policy opportunities in Texas around, can we have Medicaid pay for diabetes prevention program? We know that right now under the CDC arrangement, it's all Medicaid funded. So there are some active policy work happening right now. We had conducted a very careful landscape scan in Texas. We also sponsor an actuary cost analysis of diabetes to the Medicaid systems, around $6 to $8 billion annually. All these are really pointing to the importance need of of highlighting prevention. I would argue that it'd be great for CMMI as well as CMS to really assume a much more of a leadership role in terms of looking at policy guidance opportunities. Because when you guys speak, the rest of the country listen to you. So that's the first point I'd like to make. The second point here is that the foundation also has been on this pathway and trajectory in terms of building the capacity of two key safety net providers, the community health centers and rural hospitals and rural health clinics, in terms of developing and implementing an aggregated ACO type like model, what we call a SINT, clinical integrated network. Again, I wanted to emphasize that, for these non-traditional providers where they do not have the financial wherewithal, they don't have the data technology capacity, it's even more important that they work together when they go in discussion, in negotiation with MCOs about kind of looking at the power of having aggregated, attributed lives. I think this is a long way of saying that, there's really a much needed attention and resources paid to how do we best build the capacity and infrastructure of these safety net providers. One last point, I'll just point out that I think the notion of a much more of a community-wide population health perspective is needed as we look at the next generation of value-based payment. I think the country and all of us need to do a better job in figuring out what is the opportunities or the pathway to start bringing in some of those social service organizations. In Texas, we've been looking at, are there opportunities for food banks in the area of food security intervention? What about community health workers? So on and so forth. I think again, those could what I consider as like innovative areas where maybe we spend a lot of time early on talking about the use of technology, AI, as well as looking at the community assets. And these are the area of like opportunity for further exploration and experimentation. Let me stop there. Thank you.
Great. Thanks very much, Shoshay. I would like to highlight, as you said, creating some more infrastructure supports for rural safety net hospitals, for community health centers has been an important part of your work. You mentioned the diabetes prevention program. There's so much we could build on with this rich group of participants and all of your comments. I think I would like to focus particularly on a common theme that you all highlighted, which is the need for better, clearer supports and maybe more rapid learning about how to scale up these prevention-oriented efforts through what you might call non-traditional settings. So not just big healthcare organizations. Mark, you mentioned working with Saddleback Church. Shoshay, you mentioned working out in the community with community-based organizations. Rushina, you did too. So we don't have that much time left, but I would like to go around and ask, we've tried in these areas. There have been a lot of rural focused CMMI models that have not had good take up. Even the diabetes prevention program is not nearly one that was proven to be actuarially sound and effective outside of traditional healthcare organizations, hasn't really scaled up. So where would you all each see some lead opportunities? And maybe Mark, I'll start with you this time.
Yeah, I think, the reality is that we're seeing a shortage of physicians. By 2036, it's estimated we'll have a shortfall of 86,000 physicians, including 40,000 primary care physicians, and increasingly in rural areas. So to me, given the incredible emergence of AI in healthcare and evidence that it is very effective in helping to diagnose and even as to make assessment and treatment recommendations, that even outstrips the top physicians in the country, is something I think should be thought of that as a distributive model for democratizing and decentralizing healthcare through AI supported health tech. Obviously I'm in a company that's doing that, but we're seeing incredible interest and uptake in this in the population. We have over 200,000 members, and people are using this across the country, across demographics, across the entire country. It's not just on the coast. So I think we have to think creatively about different models of delivery and different models of care, and using AI and tech to actually solve some of the rural healthcare shortages and issues that exist. And I think there are a lot of ways to help with behavior change models through that, whether it's AI health coaching or whether it's group models. So I think it's an area that's really ripe for exploration and for imagining how we might think about reimbursement in that context. Because right now, it's not something we really reimburse for. You can barely do telemedicine, And
Yeah.
I think that would be the other thing I would say, just briefly, is that right now we have licensing in every state, and there's no reciprocity for most states, and it's really an artificial barrier. I understand it in law because it's different from state to state, but the body doesn't change when you go from New Jersey to New York. So we really had to think at a federal level, how do we address this problem, and how do we provide for more telemedicine access and not have it so restrictive? And I think that would also kind of help expand access.
And along with these technology-enabled approaches, one would hope, Mark, that it'd be easier to get the needed evidence. Abe was alluding to this. That seems like another opportunity for extending CMMI pilots. Not again, things would take 5 years to set up, but approaches that can be done more quickly and learn from and link to the payments.
Yeah, I agree. I think having CMI projects that help demonstrate this and show its effectiveness is really important. And I think we're seeing such a sick population in our screening. We do pretty in-depth biomarker analysis of over 110 biomarkers for $499 twice a year, and that gives us such a window into what the state of the health or lack thereof of the American population is. So I think it's we can come up with a select, maybe even early screening tool that allows access, and it's available all across the country, and then you enable it with AI and coaching on the back end. It becomes a very powerful tool.
And look forward to following up with you on ways to do that kind of evidence testing and scaling with more sustainable payment models. Rashina, maybe a turn to you. You are also looking at a lot of markers that you're increasingly validating for predicting risk. It's a in some cases somewhat different population and also somewhat different markers. But I know a lot of your work is hinged on connecting communities and social resources to enable the goals that you described at the outset of healthier families, especially in kind of lower income and traditionally underserved Medicaid populations.
Yeah, thanks, Mark. I think there are a lot of common themes here. One thing I think that's really critical is to take a cross-sector approach here. So the whole country, especially in sort of ACOs, have turned to utilizing care management as a means to really improve the health of populations. But care management only works if it's tailored to the right folks. and it works if folks engage. And so as we start to move more upstream, not so much focused on the reactive approach here, but really trying to focus on proactively engaging folks before they get ill, whether in childhood or adolescence or young adulthood. We have to think about where we can identify early risk. And we know that if we take a cross-sector approach to that, so integrating data, as one of the other panelists said, from the social service entities, from programs like the federal nutrition programs, from juvenile justice, from foster care. We, in our integrated care for kids model, have integrated data from multiple sectors to allow us to identify folks who are becoming ill. So we're able to see in this cross-sector data the rising risk population and then proactively engage them in care management. And to the point about utilizing AI and tech, again, it only works if folks engage. And we know that care management, less than half of people who are offered care management actually engage in it. And so we have to improve that. And so we can improve that by improving access. And there's lots of promise in tech platforms, whether it's through AI platforms for texting that is really honed to what different participants need and want and what their social circumstances look like. Those types of approaches, I think, have real promise in getting folks more engaged and improving behavior, and that leads to longitudinal prevention and better outcomes.
And then you have the more closer to real-time data from these multiple sources that not only helps you identify, but support engagement. And then as Abe was talking about earlier, getting to the sort of the validated outcomes like diabetes, pre-diabetes measures, blood pressure, other risk factors as well. Yeah.
That's exactly right. And combining that with their family context, I think, is really powerful.
Will, you had a lot of good suggestions earlier for how to make timely, more incremental changes in models rather than just trying to start a whole new major one to achieve some of the goals that you identified, especially around secondary prevention, help for beneficiaries who have some more complex conditions. Can you connect that a bit more to engaging more standalone practices, practices in rural areas, others that have not really participated as much? We've heard some good ideas on this from Mark and Rashina.
Yeah, I appreciate it, Mark. And I'll also mention just quickly, I think there's like the practice element, and then there's again this sort of range of patients that we're all sort of, I think, importantly coming at this conversation from different perspectives. And I think it's going to be really important. I'll just mention the patient piece first, which is that it's going to be really important, I think, for a lot of particularly vulnerable patients with cognitive decline or patients that are homebound to just, one, keep those folks in mind as these technologies are rolling out, and two, make sure that we're not only testing the technologies with the folks who are like eager to work with them, but also the kinds of patients that may have a harder time engaging with them, and where the technology may be more of a supporting tool for the actual practitioners who may or may not need to be there in the home. Like we put physical people in the home. We do some telehealth, Mark, but not much. I do think that this is an issue, to your point about practices in rural areas. It's going to become and continue to be an issue with how do you scale particularly models like ours that are clinicians in the home to treat really complex patients who are really expensive in rural areas where you don't have density, and what are ways that technology can be used to bridge that gap. And I do think that that is a really promising area where they can have there are going to be opportunities to use those kinds of technologies to expand access for those populations.
Great, thanks. And Dr. Sim, just to end with you, it's been a fast-paced discussion covering a lot of ground. Any last recommendations that you'd like to highlight on maybe bringing in new technologies to help reach your populations, or better ways to advance these payment reforms to support them?
Yeah, a couple of quick points here. I think one is I want to touch on one of the comments raised by the previous panelists, the notion of cross-sectoral collaboration and partnership opportunities. I just cannot emphasize enough that MCOs or health providers, they are not any asset in the community. There's really a need for increased, coordination and integration, across the different touch points that community residents have. I mean, at EHF, one thing that we have done recently was to better connect the local city and county health departments with the managed care organizations. Sometimes, we are very, very kind of like tend to work in our own silos, speak our own language, and do not do a better job in terms of understanding literally our neighbor across the street, what they are doing. I do see this, as a great opportunity. And the last point I want to mention is that, in order to make all of this work and stick together, we're going to need both healthcare and non-healthcare sectors to work together. Definitely looking forward to future conversations and learnings from CMMI and from you, Mark, and your team in terms of what's possible, what else, can we take on. Thank you again for the opportunity.
All right. Well, thanks so much, Xiaoxue and Mark, Will, Rashina. You brought a huge range of perspectives and incredible amount of experience and practical ideas for advancing strategies in these important areas. We obviously haven't solved all of this. By the way, I also want to thank the people who are joining us today and sending in questions and comments. I've tried to incorporate some, as you heard, into this discussions. We'll keep trying to do this. This is going to take some ongoing effort, but really a strong foundation to build on. I look forward to continuing to work with all of you. Thank you for joining us today. And now I'd like to turn right to our next panel on empowering patients and providers, which will be moderated by Dr. Namrata Uroy, who's a leader in this area with the West Health Policy Center.
Thank you, Mark, and thank you all the panelists for an illuminating discussion. I mean, I actually think you've teed up a lot of conversations and a lot of discussion here for this next panel, so we're excited to jump right in. Hi, everyone. My name is Namrata Uroy, Director of Health Policy at the West Health Policy Center. And as Tim and Mark mentioned earlier, Duke-Margolis and West Health have been collaborating on advancing, accelerating, and scaling value-based payment reform writ large, and I'm very much looking forward to moderating the second panel today on CMMI strategy to empower patients and providers through technology and data. So we'll kick it off by introducing our panelists today. First off, Omar Manejwala, Chief Medical Officer of Dario Health, a digital health company helping those with chronic conditions with the user-centric digital therapeutics platform. Got Kevin Volk, Director and Professor at the University of Pennsylvania Center for Health Incentives and Behavioral Economics at the School of Medicine and Wharton School, as well as the Scientific Director of the American Heart Association's Healthcare by Food Initiative. Charlotte Yeh, Chief Experience Officer at Cherish Health, an organization focused on radar-based sensor platforms that detect emergencies and risks to people's health and well-being and bring timely help. And Andy Slavitt, founder and general partner of Town Hall Ventures, an investment firm that targets early stage investments in healthcare. So thank you all for joining this panel. And to start off, right, we'll kind of level set, right? Part of the CMMI strategy is that they aim to use tools, information, and processes to better connect people to their health data, empower them to make informed health decisions alongside the patient-provider relationship. So I'm going to open it up to all the panelists with just an overarching question as to what you all see as the near-term opportunities for greater data access or to help patients engage in healthier behavior at higher rates, especially recognizing, I think we all know this, that data sharing and consumer engagement has been quite challenging to achieve to date. So I'll open it up.
All right. I guess I'll jump in first. I'll tackle the engagement side of the question. That's really where we're focused. So I think, basically the ecosystem has seen engagement challenges. Everybody knows that. The causes are multifactorial. But, when you distill the reasons down, it generally comes down to this idea that what matters to people, when it comes to engagement, what matters to people is generally that far more important than what's the matter with people. And healthcare has been focused on what's the matter with people. And so in a way, it's kind of been set up to fail. And behavioral science research consistently shows that people change when they believe they're being observed by someone who cares about them. So that means people will engage in what's relevant to them as long as it's easy to do and they feel trust and they feel cared for. So a lot of digital tools in healthcare aren't really designed from a consumer perspective. They can be clunky. They're not intuitive. A lot of times they're focused on the company's needs instead of the consumers. We see that a lot. Like go to your, hospital portal or health plan portal, you'll see a lot of that. So it doesn't feel like DoorDash or Instacart or Uber or the stuff that we use every day. It doesn't really drive towards engagement. And Abe talked about at the top of the call about these rapid iteration cycles. And this idea that this is something that the private sector is already doing. We think that's spot on. So one way that this is solved, one way that we solve it is with a direct-to-consumer lab. We have a few 100,000 people in the lab. We test ideas. We rapidly iterate to improve product in an agile fashion. So it's real. I would say, to answer your question, I think it's really about borrowing ideas that we already know work from retail and applying them in healthcare, which is easier said than done. Yeah.
Yeah, I'll add a few ideas for making behavior change easier and aligning incentives for better health. It's really striking when you step back and think about it, how often we make patients swim upstream to improve their health. So for example, a lot of patients with chronic conditions are on medications with 30-day duration. So you have to opt in 11 times a year to remember to refill your script. And we could very easily put everyone on 90-day scripts with automatic refills, and presto, you're much more likely to have much better medication adherence. But the broader metaphor is really just thinking about where are these opportunities to make it easier, the healthier choice, the easier choice for patients. Another big area where I think there's a lot of room for improvement is around food as medicine. We know that tens of millions of Americans have diet-related chronic conditions, and rates of adverse outcomes are pretty high and often are related to diet. So take, for example, the patient with heart failure who's frequently admitted to the hospital. We know they have a more than 50% readmission rate within 180 days. We know that nearly half of those patients may have moderate to severe malnutrition. And we also know from small pilots that the readmission rates can be lowered by 40 to 60% by putting them on a medically tailored meals program. But insurers don't cover those by and large. So we're paying for a lot of expensive medical care when we could probably do better from a health standpoint and an economic standpoint in just making that easier. And I think consumer engagement in settings like that is actually pretty easy because the patients are struggling with their health and would appreciate the help. And in general, I think more broadly, we should just think about patient cost sharing from the standpoint of where the value is. We tend to have patient cost sharing based on the cost of care and not on the value, but high value care, maybe we should have zero copayments. And we don't usually think about it that way as systematically as we might.
So if I can just build on that, first of all, I love Omar's comment about working with stakeholders. Everyone talks about the consumers, but we don't bring the consumers into the co-design and actually understanding what are their needs, wants, et cetera. There is, through the Edelman Trust study, that says, if patients, 64% will say, I will trust you if you understand who I am and my needs and wants, and you understand people like me. So I think that that's really important. The second is we have such an opportunity now. We know that 80% of healthcare happens outside of the home. Outside of the healthcare system and in the home. Nowadays, with technology, with ambient measurement, with remote monitoring, with wearables, we have a real opportunity to actually see how people live. Where are their pain points? Where are the challenges? Where are the friction areas? And if we identify that, we can then find the kinds of solutions that are meaningful to people, not to the healthcare system. And building on Kevin's comment about cost, You know, we always say, oh, we've reduced costs because we've reduced hospitalization or we've reduced ED visits. But no one ever talks about the cost to the person and the family and their caregivers. What are their out-of-pocket costs? And if we start measuring and show we can reduce that, you are going to get more meaningful engagement. And it's not just cost, but it's also time. Think of your average Medicare beneficiary spends 21 days in healthcare systems. That's 3 weeks out of their life. That's what the average number, and for the high cost and high complex patients, it could be as many as 50 days, almost 2 months out of the year. So imagine if we could use our technology, our AI, our approach to consumers to say, let's save you time. 24%, 1 out of 4 individuals actually delays or eliminates care or stops seeking care because of the administrative hassle of trying to find an appointment, trying to figure out if they have coverage, trying to go to the drugstore to figure out when they're supposed to pick up their prescription. They just give up. So these are opportunities that if we can make life simple, one-stop shopping, ease of use, then you will be engaging people. Nobody had to do education about GPS, but that was a real friction point in life, and people adopted because you made life easier.
Andy, some thoughts?
Yep. Look, first of all, big applause to Mehmet and Abe and the CMS team and CMMI team for what they've released. It is something I think we can all get behind. Part of the trouble with CMMI, having, of course, with Patrick Conway overseen it a decade ago, is it's a bunch of very smart people in a office coming up with very innovative ideas and trying to think through the implications of how they're going to impact people across the healthcare ecosystem. And that's very hard to do, not just the primary effects, but the secondary effects. And we haven't, to Charlotte's point, ever said to people, what can we do for you? So CMMI is a thing we do to people, not something we do for people, as I think Omar, consistent with what Omar had to say. So I think we're now starting to ask a more basic question, which is, what if we actually set up programs designed to help people solve problems that they know they have and they need solved? I think it's very much, as Kevin said, get people with the jobs to be done better than they can do themselves, which is also what Charles said. And that begins with saying, no, we're not, this isn't about putting you into a new 3-letter acronym or 4-letter acronym or whatever it is that is known to a bunch of providers and healthcare wonky people on this call, but instead starts at the other end and says, maybe we start with, where is trust already established? Who is doing a good job with people? And those are going to be people in the private sector. And how do we invite them in? And I think this is what the RFI and the new CMMI vision is all about, is saying, you in the private sector who have figured out something already about how to engage patients, jump in and connect to CMMI and let us connect to these models. So I strongly encourage people, look at this RFI, respond to it, and figure out how to get engaged, because CMMI, I think, is making an invitation akin to saying, we're going to start this from scratch in a way that works better for people. And there's lots of great ideas out there.
Absolutely. I want to touch on something that actually each of you have already, mentioned as well, and keep going about the kind of patient focus and the patient experience, and really, what is, behavior at the heart of the focus of technology, right? We've all been talking about this. And so, how might we tie together prevention and digital health technologies, right? How can CMMI think about incorporating these digital health technologies into opportunities to modify and nudge behavior in the right direction? And for many of us in the space, we know that is really quite difficult. And so, Charlotte, I might start with you in just kind of speaking, if you can speak to the importance of these kind of patient-focused models. Like, what are things that CMMI, app developers, providers should all be thinking about when designing these technologies?
So I really appreciate the question, and also hats off to CMMI for putting out this strategy that I think is pointing us in the right direction. So I like to step back and say, some 70% of baby boomers would rather have 25% healthier lives than 25% longer lives. So that means we're already starting against a backdrop where people want to be healthier because they know they can live their lives better. And I would say for technologists, for policy, for private sector, there are 3 areas that I think you should pay attention and focus on. Number one, I'm sorry, but Medicare beneficiaries 65 plus are not a monolith. There is wide variation. So at the one end, we've been talking a lot about chronic illness, multiple chronic conditions, very tough, complex cases. But let's not forget that 49% of people 70 and older and 80 and older say my health is excellent to very good. So if we are going to engage the consumer, we have to have approaches that cover that wide spectrum. And why are we also not looking at the thrivers, that 49% that say their life is healthy and they have no health limitations? Why are we not looking at the thrivers to say what's in your secret sauce that can be applicable to others? Not everybody has a family and a caregiver. Some 28% are solo agers, and more so as you age, and particularly for women. And maybe estranged from family. So how are we going to support these people that may not have support otherwise in their lives? So it's not, and by the way, we talk about empowering consumers, but how many of us actually survey by your locus of control? Because only about 1/3 of people say, I can be in charge of my health. About 1/3 say, I need someone else to tell me what to do. And 1/3 say, it doesn't matter what you tell me, it's just up to chance, it's up to God, or it's up to whatever. And if we don't understand where people are coming from and their motivation, we're not going to create that change. So one, we're not a monolith. So create the variation through our technology to approach the different types and segment properly. Number two, can we start thinking about making a frictionless workflow of life? If we are asking you to do all of this work, we know that the only way that clinicians will actually adopt technology is because it integrates well into the workflow of the practice. Well, how about for the consumer? I just told you how many days they spend in healthcare. We know that caregivers, 6 out of 10 caregivers say, I'm being asked to do medical care, medical procedures that no one's ever shown me how to do. Where is the teaching? Where are the resources? DME that was brought up. Where's the equipment that makes it easier? Like if I've had knee surgery, that I can put on a pair of pants, that I can put my socks on. If we can create a frictionless workflow of life, it could really make a difference in how people are living. What about the fact that we talk about value-based care, and there's true value in the primary care and value-based care, but healthcare is 24/7. So if, like my dad, who was 96, suddenly can't pee at 5 o'clock on a Thursday afternoon, there is no PCP. Can we not embrace that there is an emergency department that he can go to, can have the catheter that's placed because he had the classic obstruction that can happen in older men? But then when he goes home, where's the instructions to tell him how to take care of the catheter so he doesn't bounce back because nobody told him how to tape the catheter, and he could get dressed and he could sit down with the catheter in place. So let's start thinking about that frictionless workflow of life, how we can make it more convenient, one-stop shopping, and also think as we age, think about the accessibility. If you have vision impairment and light is difficult, don't make these tiny little icons, make them big, bold, that you can see them. Make them big enough that if you got a little tremor, you can still touch it. We know your fingers are not as moist. So how do you get the touch screen so it can work? What about ambient screening where you can just look at your face and get your blood pressure pulse? Let's make it easier and simpler. Hearing loss, huge issue. Now, talk about tertiary prevention. We know that hearing loss is probably one of the largest risk factors for avoidable dementia. And there's now a study that says if you have risk of cognitive decline and you get a hearing aid when you've got hearing loss, you can reduce and mitigate that cognitive decline by up to 50% over 3 years. How simple with technology that you could do a hearing test. They're free right now. You can do them off your phone, off your computer. Can we integrate that into the technology and then offer the kinds of low cost or solutions? Because dementia is high cost, and that's a really major tertiary prevention opportunity. So I want to highlight, let's talk about reducing that friction in the workflow of your life, social connection. And then the last piece is we talk a lot about chronic conditions. Can we also talk about your whole life and your attitude? How about we're waiting for the healthcare system to fix all of its issues. We're waiting for the community and community services. But what about resilience, having purpose, having social connection, having a positive view of aging? Every one of those factors is associated with better outcomes, less utilization of healthcare costs, and lower healthcare costs. Can we not tap into it? There's data out there that if you help friends and families for 2 to 4 hours a week, it lowers your risk for hospitalization by 27%. Exercise is only 20% reduction of hospitalization. So if we can start looking at that kind of holistic model, and imagine if instead of health risk assessments, we did life risk assessment. Imagine if we measured flourishing, which is a flourishing index that checks for happiness, financial and physical, mental health, well-being, social connection, sense of purpose. All of those things collectively, we could show change, and then we actually show that we've reduced the burden or the intensity on families, caregivers, and individuals. That's how we get consumer engagement.
That, Charlotte, right? It's about thinking about the workflows within the healthcare institutions, but also the workflows in our everyday lives, right? And really trying to put that in there. Omar, I'd love you to just add a little bit more in thinking about what, how you see consumer tech or tech in general just really drive these improvements in the strategy.
Sure. Yeah. And I do want to agree with Andy that this is a great strategy and tech is the way. You see a heavy focus. We've talked about prevention. The strategy talks about reducing the prevalence of chronic disease. The strategy talks about promoting healthy habits. Now, all those are driven by the things we do, behaviors, how we grocery shop, how much we move, how much we sit. There's a recent study that showed that activity isn't enough. We have to reduce our sitting times, how we sleep, how we eat. How we address our stress and resilience, how we address our mental well-being. All that is driven by the things we do. We all know that tech can change our behaviors. Like just this morning, I was dropping the kids off and I used Waze and I marked a pothole that was on the road. So it forced me to change my behavior. So it can be used as a force for good. That includes behavioral science, that includes gamification, which is not games, it's the application of gaming principles to non-gaming environments. So there's a large body of research that demonstrates that the thing that's in your pocket, that's in your hand, that you touch 100 times a day, that you always keep charged, that you will drive back home to get if you forgot it, your phone, that thing can improve your blood glucose, it can improve your blood pressure control, as Charlotte alluded to, it can improve your mood, your sleep. In other words, all the drivers of health. So we've got over 70 studies on this on our company alone, and we're not the only people, out there doing digital health. We've got RCTs. Now we've got propensity match difference in different studies. We've got third-party studies. We have multi-year studies. So we have the evidence. Here's the gap. The evidence is strong. The market penetration is weak. And whenever you see that kind of gap, you should be asking yourself, how can I scale and diffuse this throughout in order to drive improvements in value-based care? I'm a doctor. And visits to the doctor are very important. But the truth is what Charlotte said, which is most of health is generated between the visits, not at the visits. It's the hundreds of choices we make. It's our habits. And the CMMI, updated strategy reflects this. Tech-enabled care reaches between the visits and influences what matters most. So it's not just about education. Most people know don't eat the pie, right? Most people know this. It's about the path of least resistance. It's about making the right thing to do, the easy thing to do. Imagine trying to do that without technology. And then the other part I'll mention is that the strategy talks a lot about the cost of healthcare. It needs to talk about a lot about the cost of healthcare. If you want to scale something, if you want to make it cheaper, that's literally the purpose of tech. So imagine trying to improve costs without socializing, without diffusing tech-enabled healthcare. We tried that already. Everybody knows that the costs are going in the wrong direction. So the digital tools drive savings in several ways. They can replace some of the expensive costs associated with visits. They can reduce the incidence of chronic disease and the associated costs. They can reduce RX ER visits in patient care, and they can reduce the need for specialty care, which is more expensive. So all that goes under how Abe started the call, which is reducing unnecessary care and making expensive care less necessary. So it's true, I think, in healthcare that we're still in the facts age. We know that. But let me ask you this: like, if you're attending this webinar today or whatever, when has it been a good idea to bet against tech transforming an industry? Like, I can assure you, you do not want to bet, like Charlotte talked about, you do not want to bet against convenience. Convenience always wins, right? And there are powerful, perverse financial incentives that have delayed it. We saw that in the cable industry too, right? But it broke in the end, right? So all of this is really about how are we going to execute this strategy, which is an excellent strategy. How do we get to accountable and value-based care? So where do we need help? So we need help in ensuring that tech services, which cost less than in-person services and that can impact the behaviors that matter, we need to make sure that those are reimbursed effectively. Nothing is going to slow down innovation faster than a lack of reimbursement pathways. So today, for example, in my company, we're partnered with health plans, we're partnered with employers, some PBM, some pharma, but basically the idea is to drive health improvements and reduce the cost of care. And if we had better pathways, if we had more codes, we had more ability to reimburse that would just give more people access to the tools that reduce the cost of care to beneficiaries and to the system as a whole. So, and that would enable us to meet the MAHA strategy. If we're really trying to make America healthy, then we need to be focusing on the set of behaviors that impact health. And I'll tell you, today, we're not doing that, but we have an opportunity to do that at scale, and it's imminent, I think. And if the proper execution of the strategy will yield that. Yeah.
And actually, you teed me up perfectly into my next question, which is about financial incentives, right? So part of the strategy really talks about, current and future models aligning financial incentives with these health outcomes, and future models can expect waivers to support predictable cost sharing for certain kind of services, drugs, or devices. Kevin, maybe I'll pass it over to you here. What are some ways do you think that CMMI can support and implement this payment infrastructure?
Well, I think part of the key with financial incentives in terms of changing behaviors is they need to be predictable. And one of the challenges that one often sees is patient cost sharing isn't predictable. So if you want to get a patient to use urgent care instead of an emergency room, and you're in a health plan with a high deductible and coinsurance and maximum out-of-pocket limits, it's actually impossible ex ante to know how much that ER visit is going to cost versus urgent care. A number of years ago, a few of us worked with Humana on designing a new health plan called Humana Simplicity, and it's a copayment only plan. And it's $100 to go to urgent care. It's $400 to go to the emergency room. That's waived if you're admitted. So now you have a completely transparent and predictable way of knowing what something's going to cost. And I think we should think about those kind of models. We should think about incentives for health behaviors such as smoking cessation more widely. We've done a lot of testing of that. A lot of large employers have moved in that direction. And then I also think for people with chronic conditions, it's important to recognize a lot of times what they are struggling with is not a knowledge issue, it's an affordability issue. So for example, for people with diet-related chronic conditions, maybe 45% of mortality for heart disease, stroke, diabetes is related to diet, but less than 1% of healthcare dollars go there, which is obviously a huge mismatch. AHA is trying to address this. We have 25 studies in the field, but we need more federal leadership on this to really move forward faster. I think it's a really critical issue where we can think about how do we change some of these upstream incentives in ways that can have a lot of benefits both to the patients and to the healthcare system.
Absolutely. I would be amiss to not talk about the biggest buzzword that just shows up on every meeting, and we heard Abe also talk about it earlier, which is AI. And so, Andy, maybe I'll start with you. In the context of the CMMI strategy, how do you see AI playing a role in promoting patient empowerment, or what should CMMI be cognizant of in considering an approach that really utilizes AI?
So to finish the payments point first, look, CMMI has a big challenge. With the possible exception of diabetes, and I only say that as a possible exception, there's not really a lot of evidence that primary prevention, we know how to pay for and measure the results of a primary prevention model in the time frame that matters. So unfortunately, fortunately for us as humans, but unfortunately for us as model developers, things like prevention of heart disease is that's 20 years of our life to keep our blood pressure down and keep our heart healthy and all of those sorts of things. So I don't think we understand, particularly from a primary prevention point, how to design models that will reward people. Easier in secondary and tertiary prevention for sure. Um, I think that we have to be cognizant of is this is the theory behind capitation. So why do people believe that total cost of care models work? It's because the theory of the case is supposed to be that we all in the healthcare system, led by the clinicians in charge, are going to be motivated to keep people healthier and spend money on those sorts of things, as opposed to more codes, more fee for service, more let's find a new thing to pay for and just hope that it works and just create another category of billing. And I think this does feed into the question of generative AI in the sense that before we know it, and it's happening already, physicians and patients are already using generative AI for common problems and common jobs, and it's going to get easier when we have data sets, we have better data governance, we have better models, but it's already proving to be, I think, a game changer in terms of how people access information and make decisions. And, it gives us hope that we can get away from the equation of the sort of care management equation, which is we think of everybody as trying to maximize some numerator and a large denominator by doing a bunch of mail outreach or text outreach, and instead give people things like an avatar that can help guide them through decisions and jobs and so forth. So we're going to have to get creative on how we figure out how to pay for this stuff. But there's no question that unless we started to define healthcare more broadly to include all the power that's in this technology, we're going to be stuck in a very similar place to where we've been stuck.
Absolutely.
Well, and if I could just add to that, if we use our technology and the generative AI and AI, I think there's real opportunity as long as we've got the privacy, security, and the trust built in. But on the other hand, why shouldn't we be using that to not tell people what you should do? Eat better, exercise more, which are considered big burdens when you can't execute, and really use the AI and information to say not should do, but how to. And one of my favorite areas is think in the world of falls. And we have a huge expense in falls. And everyone asks, have you fallen in the last year? But nobody asks, are you afraid to fall? And imagine if we started asking, are you afraid to fall? We can then, and that's about double, it's about 60% of the Medicare population are afraid to fall. Therefore, they stop moving. If they stop moving, then they become at risk of fall. Imagine using the AI to look at balance, to look at how you're walking at home, to take a look at your gait, so that if you're afraid to fall, we can help you not fall and therefore prevent that fall. And we're measuring proactively than reactively.
And I'll give you one sentence answering your question, Amrata, because I know on time we're a little tight here. So here's my one sentence on it, which is, look, the primary driver of rising healthcare costs is labor force productivity, and AI can solve that by making people more efficient, by allowing each human being to help more people. That's the quickest and fastest path to cost reduction for companies like ours and others out there. So what we really need is reduced regulatory complexity to do just that. That's what we need to make it work and drive down costs.
That's great. And so thank you all so much for these great insights. I know we always wish these panels were longer than they actually were, and I am certain we're going to have further discussions about how CMMI can best support empowering patients and providers through technology and data. So with that, thank you all. And I'm going to hand it over to Rob Saunders, Senior Research Director for Healthcare Transformation at Duke-Margolis, to introduce our third and final panel in today's webinar, Choice and Competition.
Thank you.
Thank you.
Thanks, Namrata, and appreciate that last panel and for a really engaging discussion. I'm Rob Saunders. I'm with Margolis Institute for Health Policy. I help oversee our broader work on healthcare transformation, and I'm going to help lead a panel here looking at CMMI's third strategic pillar on choice and competition. So I want to invite my co-panelists to come on camera here, and I'll do a very fast introduction. And they have long and distinguished careers, so I'm going to give maybe just a little bit, and we have more information about each of them online. But we have Brian Blaze, president of the Paragon Institute, which is an independent, nonprofit, nonpartisan research institute. We have Martha Wofford, who's the president and CEO of Blue Cross Blue Shield of Rhode Island. And we also have Tim Groniger, who is the Chief Executive Officer at Hopscotch, which is a primary care provider focused on expanding access and care for Medicare and Medicaid patients in rural areas. So appreciate the three of you joining. We're going to jump into questions, but want to start off with a question for each of you that unpacks what we've talked about. So we've had a lot of discussion, and we see it in the Q&A, and we also have heard about it in this, with the panelists, really thinking about how we expand who is able to participate in a lot of these CMMI models. And maybe, Tim, I'll kick off with you. One of the folks in the Q&A noted that there are still many providers in traditional Medicare who have not participated, and many of those are probably independent practices who face different challenges, in terms of capital access, in terms of infrastructure, in terms of a variety of reasons. So maybe, Tim, would love to hear your initial thoughts about how this strategy can really help independent providers become more involved in CMMI models.
Yeah, sure thing. Happy to be here today, Rob. Thanks for hosting us and for hosting this event. It's been a really encouraging last week for businesses like Hopscotch that are trying to grow independent primary care in underserved areas. I think that the clarity and the desire to bring not just new participants from fee-for-service, but new operators into Medicare, Medicaid, and serving those patients in underserved areas is really encouraging. I think it's also real clarity around not just promoting participation in innovation center models as a good unto itself, but promoting participation in models that have been found to work over 10, 15, 20 years, and in particular in two-sided risk models that have been found to be very effective in delivering high quality care efficiently for the taxpayer. So, to me, the mere fact that CMS is saying this again and that it is validating two-sided ACO models is a big deal. I run a company that relies on Medicare relationships in two-sided risk contracts to sustain the business alongside contracts with Medicare Advantage payers and contracts with Medicaid payers as well as commercial. So the fact that more and more of our lines of business can be put into contracts that support an intensive, high-touch, technology-enabled care model, just the fact that is coming and is being extended and built upon a framework that is understood to work is a really big deal. Then I think it's a matter of solving some of the administrative pieces that make life in these models hard. So if you want new operators, then you have to deal with cash flow issues. You have to deal with the reality that shared savings models, while effective, are also complicated. They take a long time to pay out. Even if you're performing very well, you might not be paid for 18 months from the commencement of a performance period. So there's a number of economic issues there. And then there's all of the difficulties of regulatory life as a small provider operating in small towns or rural areas. So licensure timeframes, regulatory policies at the state and local levels can make it very difficult to bring in new providers. Then we can compound those problems with CMS administrative issues. So really excited for the focus that Abe and team have put on this, promoting this type of provider. I think that there's quite a bit of work to do, but I think the policy direction is good.
Thanks, Tim. And Brian, maybe I turn to you next. So like any new strategy, it relies on work that's been done before. And I know you've done a lot of thinking, looking at where CMMI can go, and in fact, put together some reports, especially in the first Trump administration, looking at where those strategies may be most effective. So would welcome your general thoughts on how to advance choice and competition through CMMI models based off of what we've learned before.
Yeah, Rob, thank you. And first, I want to say I'm thrilled with the selection of Abe to lead the Innovation Center. I've got to work with Abe for most of the last decade. Started working with him at the White House National Economic Council, and he is principled, hardworking, and I really think has the creative vision necessary to drive meaningful reforms. at CMMI. One of the things, big priorities of President Trump was what we could do to improve the American healthcare system by empowering patients and consumers with greater choices, greater control over their financing in a market where there was more competitive forces and where we had a regulatory environment that allowed innovation to flourish. And if you think about the difference in the healthcare sector with so many of the other economic sectors, we really don't have the forces of creative destruction involved with healthcare, where you've got a process that is continually focused on lowering costs and improving quality. And a lot of the basic problem is that patients don't have control over the financing. 90% of the expenditures go through government bureaucracies or insurance company bureaucracies. So what I am really excited about is an initiative to tackle big issues in the Medicare program. So much of our healthcare sector has built itself around Medicare payment policy. And Medicare payment policy leads to a lot of unintended consequences. So one really good example is that Medicare pays much more for a same service delivered in a hospital than in a physician's office. It leads to consolidation with incentives for both hospital systems and independent providers to combine, which reduces competition and which we know raises prices throughout the entire health sector. So what are some creative ways to get at that really fundamental problem of the differential in payments across different settings? I'd say another example here, and it's not, so we've got problems with federal payment policy. We've also got a lot of anti-competitive policy at the state level. So states enact barriers that prevent providers from practicing to the top of their ability, and that prevent new supply from being able to come into the market. Really, we have a system that is so built to benefit the status quo and the entrenched providers over entrepreneurs and innovators. So what are there ways that these models can creatively think about breaking down some of these state barriers that raise costs and that lower quality in the market?
Thanks, Brian. And Martha, I want to turn to you as well. So one of the parts of the strategy talks about involving Medicare Advantage plans in CMMI models. And there's really a number of nuances when implementing CMMI models with MA plan partners versus, say, doing so through traditional Medicare. And would very much value your thoughts and the work that you've been doing in Rhode Island on where CMMI models can better engage MA plans, and what do you see sort of as the future that can go there?
Sure. I'll give you three thoughts. The first is that, as I think we all know, MA plans have more flexibility than exists in fee-for-service Medicare. And so you have the ability to target benefits or build models specific to the population. When I was on the provider side in kidney care, we had really good success, for instance, building and transportation benefits for dialysis patients working in partnership with payers. Here in Rhode Island, we were doing a lot to better support the highest cost, most complex members, whether that's oncology or other spaces. And so I think what would be helpful is if CMMI ideation for some of these models started with a Medicare Advantage lens versus fee-for-service, so you can actually use the flexibility. Because as we get brought in, whether it was the VBID model or others, like that cost a lot to the government. I don't think it was successful, but it's just been sort of clunky about how the two interject. And I would say I have a ton of excitement around the food as medicine effort. That's been something we've put a lot of resources into healthy food to our Medicare Advantage beneficiaries in Rhode Island, but we've had to cut it back as we've had trouble with the funding in Medicare Advantage. So that's one. I think the second is it needs to be a positive ROI for it to work for payers, right? So reimbursement needs to be worthwhile. The administrative burden can't be as high as it typically has been. And then the third thing is just, I think the time is right. We are at a point for Medicare Advantage plans, particularly those that are local or regional, where there's just so much cost pressure from the changes that have happened in risk adjustment, but really also just because of utilization is so high, medical cost is so high. So I think there's a lot of opportunity and urgency for innovation in Medicare Advantage. So would love to see, an area we really struggled with is on specialty care, like where there's sort of an approach on oncology and renal. There's a whole lot of high cost specialties where we haven't made a lot of progress. So trying to figure out how to work with CMMI on the specialty side would be really exciting.
That's helpful. And maybe I'd like to go deep. Each of you have raised some really important issues that I want to sort of double click here on. Maybe Tim, start with you. One of the key themes in the CMMI strategy is making sure that models are able to be implemented in rural areas and take account of the fact that providers in rural areas are going to have some different strengths and also some different challenges than providers in other parts of the country. You've done a lot of work throughout your career and thinking about how you bring together providers to form different types of value-based payment or accountable care approaches. Would love your thinking on where is there opportunity to really better support those rural providers and some of these CMMI models.
Yeah, absolutely. So it's an exciting time in value-based care, partly because we've seen the growth, the explosion of different types of models, and then the whittling down of models that don't work, and then the rejuvenation of a number of specialty models that have worked really well and have matured alongside the primary care models that have succeeded in value-based care. And so Martha mentioned renal models. I think we have a number of good opportunities and options for whether companies to work with or care pathways to build upon that support better management of patients at risk of advancing kidney disease or that do have end-stage renal disease. The challenge in rural oftentimes relates to manpower, availability of resources, drive time, and access first and foremost. And so opportunity that I think is out there for companies like mine, but also for CMS generally, and for policymakers generally, is to connect some dots in rural. And I think that, we all have a desire. We are all living in a world where everything is AI and virtual. The reality is that to connect patients to virtual specialty services or some of these really higher tech services that are really impactful, you need an in-person nexus to do that. That could be out of a primary care office. It could be out of a rural health clinic or an FQHC. It could be out of a tertiary referral center that convenes a number of these services and connects patients. I think that needs to be organized around a really strong and aligned business model in a two-sided risk, whether ACO reach, direct contracting, whatever the next flavor is, as well as usually another set of relationships with plans around Medicare Advantage and Medicaid and the like. So connecting these new specialty services locally in a harmonious way for a patient experience, I think is a really big opportunity. And then picking at some of these really persistent local regulatory issues, usually requiring some regional coordination. And CMMI has been rolling the rock up the hill on regional coordination with the AHEAD model and successive iterations of coordinated planning. I think it's frustratingly slow moving, but really important and impactful when done right.
Thanks, Tim. And another piece in the strategy talks about the need to streamline and standardize model design features. That can take the case of trying to streamline quality measures, but there's a variety of other pieces here that can help reduce administrative burden. And we've seen that there's been longstanding efforts at this. The Healthcare Payment Learning Action Network has done a lot of work over the last decade doing that, and that was, of course, just re-envisioned today. And there's been state transformation collaboratives in Duke's home state of North Carolina. Their North Carolina State Transformation Collaborative has done a lot of work on trying to stand up to bring folks together to align quality measures, but that's very hard. And so maybe Brian, turn to you. Would love to hear your thoughts on where there's opportunities to help in that standardizing model design features and reducing administrative burden. Where can CMMI start in trying to unpack that really knotty challenge?
So tackling the quality industrial complex is a difficult challenge. And it has been, we tried to streamline measures in the first term. I think that here I am a student of our new FDA commissioner, Marty McCary, and the work that he has done to sort of pioneer appropriateness measures, and not so much just looking at the quality of given procedures, but a lot of procedures that are done to patients are unnecessary. And how you get at the fact that, yeah, it could be a perfectly done procedure, but if it wasn't appropriate or if it wasn't necessary for the patient, that's a really important thing to know. And I think what he has done through, choosing wisely and comparing providers to other providers that do the same thing, and then you can get the feedback from the specific physician group on appropriateness of practice patterns, I think is an important, to me, that is more important than trying to figure out which of the 300 or so quality measures we should try to simplify. It is to think about what we can do to ensure that there's more appropriateness of care.
I appreciate that. And Martha, I think you've been doing a lot of thinking about this as well, and again, recognize that there are differences in implementing new accountable care models and new value-based payment models through Medicare Advantage than through traditional Medicare. But are there lessons learned that CMMI can think about as they're rolling out different types of models and learn from lessons about how to streamline these?
Well, I love Brian's comments about appropriateness, also about site neutral. I think on appropriateness, I also think about whether we can't sort of centralize the evidence base in a way that we can develop medical policy that people can agree on. I mean, I think there's a lot of data out there, and I think in general, it's not in a shared format that is sort of, we all have people use different databases to determine the next step clinically. And I think there's ways to align on what the evidence actually says and then use that to drive the behavior. It's certainly something we think about with areas like utilization management, which are super controversial and we could do a lot better. But if we could align on medical policy, I think it would help and use the technology we have now to actually feed that. But I think on the different models, having been on the provider side, it was super challenging, right? To have all of these different models to be running with different metrics, different targets, different, risk adjustment, different methodologies on quality. And so I think the more that we can standardize is sort of obviously, I think, a good thing. And I think we're at such a great moment in terms of technology and the ability to use AI and just lots of sort of basic automation to drive the process, provide the data, make it transparent, use it to help providers actually manage the population better. So I think, and I'm talking while I think, we got lost Rob and we got him back. So I think there's just a ton we can do to align on the data side, I guess is how I would finish that, Rob. Not sure if you caught all that.
And speaking of technology, my technology immediately crashed. So I caught the beginning and end and was furiously trying to join from my phone. But Martha, I think you're noting that there's a lot in terms of technology that we can learn here. One point, maybe to switch gears a little bit, building on the point that you raised in your opening, is many of the providers we haven't brought in to value-based payment in the past has been on the specialty provider side. And I know you've done a lot of thinking in a variety of settings on ways to bring in more of the specialty care side, both from your professional career, but also on the broader across the healthcare side. And would be interested to see CMMI's thinking about increasing choice and competition. How does it start to really effectively make models that are able to bring in more of the specialty care, where there are a lot of questions here on choice and competition?
Was that for, who was
that?
That
was for Martha. That was for you, just thinking about some of the work you've done.
It's a good question. I think that the challenge with the specialty model is sort of when do you trigger it and what is the event that starts it? Is it a collection of bundles? I don't have a good answer. I think the view of there's certain conditions, oncology and renal are two good examples, particularly end-stage renal disease, where you're no longer seeing a PCP. And so the attribution is pretty clear that it should be with a specialist. but I think there's a whole lot of other conditions where it's really vague about who should have the attribution. And so when somebody then actually needs a specialist, is there a point where there's shared accountability between a primary care physician and the specialist, and how does that hand off, and where do you trigger that event? And so I don't have the answer of how to better manage a bunch of these other conditions. I think, like many payers, cardiology is our top spend, and I don't think there's a lot of good solutions out there of how to better manage patients and many entities that are taking risk on different parts of cardiology. If there are people, please reach out to me. We're certainly looking for more help in managing these populations, because we typically attribute our lives to the network, to the local providers here in Rhode Island, but they don't have the capabilities to manage the most complex patients. So it's a bit of a gap that we're trying to fill through contracting with entities that will take downside risk to manage specialized populations.
Thanks, Martha. And final question for everybody here. So one of the cross-cutting themes of this strategy has been that protecting the federal taxpayer, and as Ibsen noted, the need to try to demonstrate early and ongoing indicators of savings. So recognizing we've got about 4 minutes left here, I want to save a minute or two to wrap up. From each of you, what would you say is the sort of 1 minute of where there are opportunities to balance that sort of early indicator savings with the need for predictability and model methodology? And Brian, I saw you went off mute, so maybe I'll have you start and work our way through.
I would say, a lot of conservatives were not fans of CMMI originally for increasing bureaucracy and centralized planning. I was more supportive of the aim because of the need to reduce the spending growth of our healthcare entitlements. I consider it the most important domestic policy priority. So the fact that CMMI has so far failed to reduce the cost growth in those programs is my major concern about the Center for Innovation. I think it has sort of a last opportunity here to demonstrate that there are people at CMS and within this world that can develop ideas to reduce the unsustainable trajectory of these healthcare programs. And I think there are examples in the private sector that could help sort of think through how you can do this. A lot of it, to me, is realigning the incentives, not so much for the provider, but for the patient. So we have the example of California and some private companies using reference-based pricing, where they set a price point and people could go to any provider that they wanted, but if they went to one that charged more than the reference price, they were on the hook for the residual. What happened is that people got engaged. They started shopping. And then what most important is that the provider side of the market responded, and they lowered their prices 20% just because of what was happening on the demand side. So I think what we need to do is empower patients and have demand side features that cause the provider side of the market to become more cost efficient. And I am hopeful that sort of with Abe's leadership and with Dr. Oz, that they can develop a set of models that actually do big things in these programs that we can learn from. And I applaud their focus on taxpayer savings. I think that's really important. And it's clearly something that has been missing to date from the center.
Well, I know we have 1 minute left, so I'm going to have to jump to well, actually, yeah, Tim, if you have a quick note here.
Yeah, I mean, just quickly, I think it's important that focus on sustainability and affordability is really important. Innovation Center is the R&D function of CMS. It's not the entire policy apparatus. Long-term affordability and sustainability falls as much on the rest of the agency and on Congress as it does on the Innovation Center. So I think Innovation Center's metrics of success should be continuing to grow in the two-sided models that work, continuing to create optionality for other policymakers. But I think that these bigger sustainability questions go well beyond what the Innovation Center can take on itself.
And Martha, any final words?
Well, I would quibble with that a little bit. I just think we've got this absolute obligation to reduce costs in the system. I think we're failing on affordability across healthcare. And so I think we got to be looking at any way that we can reduce cost. And I think with really high and increasing utilization, we've got to use technology very differently in data than we have to get, I mean, it's kind of trite, but the right care to the right person at the right time. You can reduce hospitalizations and reduce costs. I've seen it with kidney patients, and it's pretty dramatic. So I think there's opportunity. And I think the more that CMS can do to set the standards so that we can use AI to actually innovate and bring this to bear, I think it would be super helpful. So I'm super excited about the CMMI strategy and the work that we've seen to date and looking forward to participating.
Thanks, Martha. Thanks, Tim. Thanks, Brian. So this concludes our webinar today. I want to thank all the speakers who took time to share their insights. This event was made possible by our staff here at the Margolis Institute. I want to particularly call out Audrey Ford, Wendler Bai, Frank McStay, and our communications team, Hannah Vitello, Luke DeRocher, Patty Green. And also want to thank West Health, who's been a great partner in supporting our work, including today's webinar, and the CMMI team, who also partnered as we were putting this together very quickly after the announcement. So thanks again to all, and look forward to next steps together.